is a big key to this. Okay? When you're talking to your patient, part of that patient education is talking to him about his risk factors. Right? You guys are doing cardio. There's a whole bunch of risk factors that lead you to have cardiac problems, right? Yes. Lifestyle issues, big ones. Yes. Being overweight, big one. Family history, big one. Right? These are the things that we would talk to our patient about. That's part of public health. Where did we get that information from? Where did we get those risk factors from? Statistics that we've talked about throughout all of ID, where did those come from? It's these guys. Okay? Public health first. They're the guys that give us all this information so that we can pass on to our patients. Okay? And it isn't just that. I mean, they do everything from water, right? Clean water stuff, all the way to tracking down the main reason for the disease to start with. Right? Typhoid malaria, prime example. So these guys do a lot of things. We kind of minimize it because we don't even realize that we're part of it. But these guys are extremely important. These are some of the lectures that we're going to cover. These are some terminal learning objectives. Epidemiology. These are some of the learning objectives that we're going to cover during this little go around. And we'll start here. What's public health? This block has a lot of definitions in it. So understand that some of these definitions are what's going to be on your test. Right? Just the nature of what it is. These are really hard to put into scenarios, so we will have some definitions in your test. So public health overall is basically the science or practice of safeguarding and enhancing the health of the public. Okay? Understand that aspect. It is the health of the public. Okay? And what do? They go out, they organize efforts like mass vaccinations, right? What we call rodeos, right? But they do that on the civilian side of the house. We're part of that ecosystem within the military, right? Have they told you guys when you guys can go down and get your vaccine, your influenza vaccine yet?
Not yet.
No? Okay. Well, if you do go down to the bottom of the hill, you will see me that morning, because I'll be the provider going. And in turn, when you guys graduate, you guys will be doing the same thing for your units. That's all part of public health. Right? We are trying to ensure that the mass population stays healthy. Okay? Overall. It's literally what they're supposed to do. Right? Or what they do. Okay? Epidemiology. What that is a branch of the medical science that investigates the distribution and determinants of health-related states or events that cause specific problems. That's it. Right? Within specific populations. And this thing incorporates epidemiology, incorporates biostats, social sciences, environmental sciences, health influences. Covers a lot of things when we talk about public health overall. The bigger aspects to this really become when we talk about influencing health outcomes, when we talk about healthcare, when we talk about education, and when we talk about socioeconomic problems. When you guys start practicing in the military, you're not going to realize that we have any of those issues, right? If I prescribe something to you, you're going to go get it. If I need you to go get an x-ray, you're going to go get it. There is no copay, there is no insurance, there is none of that stuff. But when you do decide to go practice in the civilian sector, this will become a large aspect of how you decide what you're going to do with your patient. Okay. A lot of it is you're still giving them the same information. The question really becomes, will that patient be able to get what you want them to get in order to help them get better? Or to prevent them from getting sick? Right? That's the second P in your subnote, is the prevention piece from them getting sick. You guys understand the differentiation between the first P in your plan and the second P in prevention? Yes? So, we'll start there with the highlighted distribution there. The distribution aspect is who, where, and when. And all of that is really guided by age, sex, location, time, and ethnicity. You guys remember what all those are? All those are the things that we generally looked at when we did ID. Right? Who did it affect? Young guys, old guys, everybody in between. Right? Gender, did it affect males more than females? Location, geography, remember that part? Huge aspect of ID. So that's a distribution aspect of this piece. Now the frequency would be, how often does this happen? The question is, how often does this happen within a population? And then we break that down, how often does this happen within a specific population? Right? How often does this happen in males? How often does this happen in females? Right? How often does this happen in children versus adults? So that's the other determinant aspect of the frequency in your epidemiology. The other piece with the frequency aspect is burden. You guys know what burden means in relation to public health or medicine? What that means is, how much is it affecting the populace? How much is it affecting the socioeconomic aspect of the population that you're in? Okay? It comes with a lot of problems, right? You miss work, how much money did you just lose because you missed work? You live paycheck by paycheck, you didn't go to work, so now you didn't get money to pay your stuff. Right? That burden continues to accumulate. If I'm sick, my copay is $100. I can't afford $100, so I can't go. The burden continues to accumulate. If you get sick, how many other people are you going to get sick because you can't go get seen? Okay? The burden is how it's affecting the overall population. And it's one of the things that we try to define when we see frequency, so that we don't spread it and the burden doesn't get any worse than it already has. And there, that study to control health problems, it really refers to prevention, reduction, or elimination of whatever the problem may be. The other aspect of public health in regards to control is policy. Policy. Public health does a lot of things. One of the bigger ones is the tobacco stuff. Not smoking in public. Actually slapping tobacco may cause cancer on cigarette boxes. All that's driven by public health. So control's a big one. So their epidemiology, who gets sick, how often they get sick, why they get sick, and what do we need to do to prevent the public from getting sick. There's two basic fundamental assumptions that we make when we talk about this kind of stuff. These guys usually use various design studies, observational and experimental methods to come up with these things, okay, for public health. Right? One there, this stuff doesn't occur by chance. So when you go someplace and stuff is happening, it's not just happening randomly. Something is spurring, something is causing it. That's what public health is going to look for. What is the cause, or what are the risk factors that are causing this problem right now? Okay. And that's usually what they go do. It's part of the does not occur by chance. Okay. Something is happening. Now we got to figure out what's causing it. Okay. Not distributed randomly in the population. This goes back to our last statement where there's very specific, right? Age, sex, location, socioeconomic standards, behaviors, a whole bunch of different things can lead you to the distribution not necessarily being random. Okay? In certain population sets, we know that in lower socioeconomic areas, they have a higher issue of being having medical problems than in higher socioeconomic areas. We know that. Okay. So we know that it's not a random thing that occurs in that population. So that part generally tells us something is happening. Right? So we can go from there, especially within the higher prevalence population groups. Here this is just telling you who's a PT study. Anybody gonna raise their hand? Usually those are the first guys to raise their hand. So if you take one of these two studies, right, and we compare all ourselves against this one person, do you think that makes sense? His health compared to my health, compared to your health or anybody else's health, would it be the same?
No.
Correct. It would not be the same. But that is what we do as providers. He comes to see us because something's going on. I'm going to take care of the problem. That's not what public health does. Okay? Public health does not look at one person, either of these two studs, and compare them against the rest of us. They take a look at the entire population set. Right here it says the aggregate, okay, of a population, and then we go from there to figure out, hey, what are the risk factors? What's keeping these guys from getting help? What do these guys have that's causing them problems? That's really what this stuff means. We don't look at one person, we look at a general population overall in order to figure out what's going on. Identifying etiology of a disease and relevant risk factors. Okay. What causes disease, what increases the risk of getting it. That includes biological, behavioral, environmental, and social factors. Determine extent of disease in the community. How common does that happen? That's part of the frequency that we just talked about. Who within that community is actually getting affected, right, with that specific disease? Right? What risk factors are causing these people to get these problems? That also leads to burden issues, right? Because if they are having a problem within a specific population, that causes a burden within that population. Okay? Study natural history and prognosis of the disease. Understanding the disease and how it develops, how it progresses, and how it generally resolves itself. That's literally medicine. That's what we do. Right? What we do. But again, that's part of it, because if we understand how it develops, then we know what we need to tell people so that they don't get it, right? That's pretty if they do get it, we understand how it's going to progress in your system if we don't take care of it. Right? It makes sense. That's generally what we do as medical people. When they come see us, we give them stuff and they're done. Right? And then at the end there where it says prognosis of the disease, how's it end? Do they get better or not get better? Is it self-limiting, not self-limiting? Is this a prion type disease where there is no self-limiting or medication that I can give them, and it's got 100% mortality rate? Okay. Understanding the whole entire system is part of what we and they do. Okay. Evaluating both existing and newly developed preventive and therapeutic measures. What kind of new meds do you have? Are you up on all your vaccinations? Okay. All those things are part of that statement right there. Right? Part of that is, for example, when I came through school, right, there was no such thing as JAK inhibitors. Okay. I learned that after the fact. Okay. You guys are learning that while you're here in school, you're in pharmacy. So there's a whole bunch of new things that are going to continuously come out that we, as providers, have to keep up with, so that we can ensure that we take care of our folks and overall public health. Right? And there provide foundation for policy. Public health deals with laws, public health deals with budgets, public health deals with interventions that we can actually do that are based against evidence. Okay? Everything that these guys are doing are evidence-based, so that when we talk to our parents, we're giving them the best information that we possibly can, so that they can make an informed decision. Okay? They can make the best informed decision they can. And there it's preventive is primary. Be proactive, not reactive. I remember for ID, everything is preventive. And if we can keep them from getting sick, then you're going to be better off, right? So here we're going to start with the middle there where it says burden in terms of what? Burden of disease we kind of talked about. And that generally is the overall impact of what health problems do onto a population. If we know there's a specific population that's going to be decimated by a specific disease process, we can use HIV as an example, right? Who have sex with men were the most common. That population was the one that was going to get decimated. And they were going to have the ones with the most burden attached to that. And that is mortality and morbidity and economic cost. All of that stuff goes with burden. Okay? All of it. So, why are identifying factors like reservoir transmission, risk factors, or exposures important? All right, let's look at it this way. PAs on average make about 50 to 70 bucks an hour. If they work 8 hours a day, that comes out to what? 400, 560 bucks a day? Yes, more or less. Let's say you don't go to work that day, and you're the only provider there. How many people did you not see that day? On average, if you're doing general medicine, like walk, 20 to 25 people. Really will be some. Okay. Fairly more, really depends on where you work. So that is 20 to 25 people that are still sick, that may not have gone to work, that may be spreading it to other people, jacking up that burden. Right? Now imagine that in a group where they don't go to the doctor because they can't. And they just continue doing what they can. Going to work, spreading stuff, going home, spreading stuff. If they have to go to the store, maybe spreading stuff. That burden continues to accumulate. Why is it important? because it gives us actionable knowledge. If we understand how we can intervene to prevent some of this illness. First part, we can kind of sort of stop it. We can keep it from spreading. We can keep it from going to everyone else and causing more possible medical burden across different groups of people. Why it's important. We can also control outbreaks. Right? For example, the measles, crossing over 10 states now. And the CDC let the measles reaction team get fired and then just hired them again. So these things are going to cause us some medical burden. Right? That's why it's important. What do those burdens do? Keeps us from spending money because we don't have any, we get sick, and we don't go to work. Okay? For us, it enhances our training grounds. We have to stay up to par. Although we have to do 50 CME a year, which is what's required to maintain your licensure or your certification, we still need to read other things to make sure that we keep up to date with a lot of the newer stuff that's coming out. So when we do talk to our patients get the best information they can from us, right? They come to see us because we're supposed to be subject matter experts. So we need to be able to give them the best information we possibly can. When we do realize, School of Public Health realizes there is a larger burden due to a specific disease process, that also opens up funding for people who, if they want to go redo research. If any of you guys want to do research, funds are out there. You just have to apply for it. And see if they'll give it to you so it'll support your research on whatever you want to do. Ultimately, understand the baseline disease in order to prevent. If we know what normal looks like, we know what normal looks like, then anything out of that norm is abnormal. We know within certain population groups, there's X number of people that are generally sick, or maybe sick. Okay? That is a standard. Okay? We're never 100% healthy. We understand that concept. And we can use Lyme disease in Connecticut to be that point, right? There were some people there that generally got sick over time, but got better, until there was a cluster of people sick, which told them, public health, that this was abnormal. Although there were people generally in this area that were sick with those symptoms, we never had such a large cluster of people sick, okay? Which drove them to go down there and figure out what's causing the problem, where it's coming from, how it's progressing, and how can we take care of it. And they're ultimately there at the bottom, policy and regulations. That's a huge aspect for them. It's a huge aspect for us. Okay? They dealt with a lot of wearing your seatbelt thing, okay, because of accidents. Okay? And that's one of those big giant policies that they put. Food safety is another huge one that they push. Okay? So here's a whole bunch of their achievements, immunizations, right? Child infant mortality rates have dropped drastically because of immunizations. There's your vehicle safety thing with the seat belts. So we're gonna do this. Aside this stuff right here, right? This is just a simplified slide. Okay. You guys see that? Yeah. All right. want you guys to see it. A lot of the other things that these guys have done, okay? And a lot of this stuff is us. It's us. Me, you and I, PAs, when we're out there talking to patients about, hey, this is something that you need to do or should do in order to stay healthy. Okay? They're the ones that dealt with the vaccination. They're the ones that controlled a lot of the infectious disease stuff, right? A lot of that stuff is due to fecal oral and water contamination issues, improved sanitation and clean water. We've talked about contact tracing and quarantine. They're the ones that came up with this, especially when we deal with tuberculosis or HIV. Right? Filtration and chlorination for drinking water. This was not a thing until they pushed it and made it policy. Right? And granted, this is policy here in the U.S., even though certain parts of the U.S. so has to jack up water. But when we compare ourselves with overseas, okay, we're head and shoulders above a lot of that stuff. Tobacco control. They're the big ones pushing that would cause cancer and heart disease. And they're big ones there for the policy and the regulations that they actually added on to the tobacco stuff. Okay. Maternal and child care. Child health improvements. Big deal for pushing prenatal care and safe childbirth practices, which we didn't have before. Right? We still use midwives. They were used before, but now we're using it just in a safer method, with safer practices. Contraception and family planning. That was illegal before. They pushed this. Reduction in maternal and infant mortality rates. Motor vehicle one, safety laws. Okay. Cardiovascular disease. Healthy diet, exercise, smoking cessation. Who's going to tell their patient to do that? Everybody will tell their patient to do that. It's standard stuff that we usually tell them. It came from them. It came from public health. It came from all those risk factors that they have. Screening test. You guys have your USPSTF stuff downloaded on your phone, or you can go to it on your laptop. That tells you category A, B, C, D, or I. That's where this stuff comes from. Not only will that help the patient with preventing future issues, but it also pays you extra when you submit that to the insurance companies. Some insurance companies, not all insurance companies. It's crazy. Okay. Nutrition and food safety. Looks like these guys have their hands in almost everything, right? Universal health awareness. Okay. Public education. You guys will be doing the same thing, but you guys are doing it at an individual level. These guys are trying to do it in a mass scale for the total population now. So ultimately there, use of population level data to identify diseases, causes, risk factors, and trends, right? Some of that data and stats that I pulled up for some of the ID stuff has come from them, because they're the ones tracking this stuff, so that we know where certain things are more common. And then if you see trends, you can do the same. And I will tell you, depending on if you go to a sustainment brigade or a BSB, you may have a run of STDs for some strange reason. It happens there a lot. Okay? And you will see that trend. Okay? So that you can go figure out, hey, what's going on? Okay? Or you can talk to public health and let them know. They do work safety stuff. Okay? You guys haven't heard of OSHA? They follow OSHA stuff. They help us prepare for some pandemics and bioterrorism stuff. These guys work huge for the COVID-19 stuff. Whether it worked out or not, they're actually working on global cooperation to come up with one one standard across the board. Overall, deaths reduced so that we have longer lifespans. And that's an outcome of what they've done for us. So there's some summary of how to shift in medicine from just treating illness to preventing disease, prolonging life, and promoting health. We do one aspect of that, right? We're just treating the illness, but we also try to do the preventive piece, whether we know it or not. These slides are not going to be on your test, so don't worry about it. If you do want them, let me know, and I can hang on the canvas for you if you want. Just let me know. Here's a whole bunch of causes of death. Lifestyle risk factors. They figured this stuff out. This is the stuff that we go off of. Okay? And this is as of 2023. Okay? Leading causes of death worldwide is heart disease, cancer, CVA. Right? You don't know CVA, cerebrovascular accidents, and like a stroke, and then COPD. The lifestyle risk factors are what we usually tell our patients. So we are part of this. We're just not realizing how much of a part of this we actually are. Okay. I'll put the joint pub up here for military public health. The Army has like 3 or 4 different ones. AR 40-5, AR 385-10, and AR 600-63. I am not too sure about the Navy or the Air Force ones, but they also have public health folks. Okay. So we're all doing this. We have the joint pub we can follow. The big deal here is force health protection is part of the joint function of protection. Force health protection with HP. Okay, services promotes improved or conserve the behavioral and physical well-being of DoD personnel. Okay? Measures enable healthy and fit force, prevent injury and illness, and protect the force of health hazards. It's literally what we do. Literally what we do. Okay? The difference here is that they're looking at a much bigger picture than we do. We're still perfect. All services have something in relation to public health. Right? So here, DoD 6204, okay, it's a DoD policy and responsibility for implementing force health protection across all military service, Army, Navy, Air Force, Coast Guard, Marines, generally Coast Guard whenever we're operating under DoD, because they belong to Homeland Security. Okay. So for force health protection, all measures are taken to promote, improve, conserve, and restore physical and mental well-being. Okay. What's not on here, what I didn't put on here, is disease prevention. Which is a huge aspect of what we're going to do, and deployment health, which is another huge aspect of what we do, whether we're gone deployed health or come back from deployment health. Okay? Those are all on there. You should be on there. I didn't put them on there. You're going to be doing a lot of this stuff as part of your daily jobs. Okay? So here's some achievements. Some of these you may have heard because they've got hospitals named after them. Walter Reed Hospital in DC, Darnell Hospital Hood, Lovell. He was a general hospital in World War II. It was named after him. And then something for James Tilton. I couldn't find anything for him. But the medical profession within the military has pushed a lot of medical forward. A lot. These are just some other folks that have some great achievements with public health, helping medical push forward. So, before we go to try to answer what's your role in public health as a PA, who's in charge of the troops? So in your unit, who's in charge of the unit? The commander. Okay. If I put that on the test, please, by all means, get that answer right. Because it's the same across all services. Right? Commander's in charge of all troops. Okay. Your job is his SME. Your job is his subject matter expert. Your job is to bring up any problems medically that you see that need his help in fixing. Like you got 30 STIs, and something going on, and you may not be able to fix it. But as we move on to your role as public health as a PA, that should generally go beyond just diagnosing and treating an individual. You really should look at individuals, number one, holistically. You will figure out how you want to treat patients. You guys will figure that out once you start working on your own. Okay? I look at them holistically, but within that holistic view of that patient, they are attached to other things. They have families, they're part of organizations, they're part of communities, right? That increases that sight picture to the community, to the larger population, which is what public health does, which is in a small part of what you generally do every day anyway. Okay? So remember, your role there is health of the population as much as it is the health of the individual that you see, right? How can we apply these concepts, right? So what are some of the core concepts that we're talking about when we talk about public health? For us, prevention is huge, right? Second B, so no, if we keep them from getting sick, then no burden later on, less medical care that this guy's going to need for immune. So that sort of works out for you. Immunizations and screenings, right? Keep them immunized, keep them screened well, cardiac stuff, colon stuff, vaginal stuff. We can keep our patient better off, right? Surveillance. You're doing that as an individual provider. If you get a run of people with, watery diarrhea, something's going on. There's a trend there. You just need to figure out, do I need to talk to public health about it for contact tracing, or do I need to figure out where this thing actually came from so I can call the pool, because everyone here has crypto, right? Because they were in a pool with poop for some reason. Maybe not. Okay. Health promotion, another huge thing that you do. Right? If you show up to me and you tell me that you want to quit smoking because you're a 50-pack a day smoker, that's part of what you do. Right? Health promotion. Those are all core aspects of what you're going to be doing as a people. Okay? You're going to be doing anyway. It's just on a smaller scale. Hopefully prevent population problems. So some of these concepts in the military are more so for medical readiness. That's ultimately one of the reasons why we are and we do what we do is because of medical readiness. You need to keep your folks up and ready to go whenever you're going to go, wherever you're going to go. Right? Really what you're going to do. Right? So you just need to make sure that their medical readiness is ready for whenever you have to take off. That would include vaccinations and screenings, medications if they're on any medications. Now, here it says, how will you engage in the public infrastructure of your practice? for us, our practice in the military, it's in relation to force health protection. It's in relation to force health protection. Why? Because you need to get your guys ready to go. Yeah. Through preventive care, through health outcomes, through all those things. Right? Because you need to make sure that you guys are as healthy as possible in order to be able to deploy whatever they need to deploy. Right? And then ultimately their infrastructure for your practice, you don't have to concern yourself with that when you're within the military. When you're within the military, all your clinical engagements will be taken care of. What does that mean? I got to send them to the lab, I can send them to the lab. If I got to get them some medication, I can send them to the pharmacy. If I get them some x-rays or MRIs, I can send them there. Okay? So infrastructure-wise, within the practice, you don't necessarily have to worry about that. Ultimately, as a PA in the military, you're shaping your unit, medical readiness, population resilience overall, and you're going to do national security stuff because you're getting ready for any kind of mission that they need to go. All right. I like quotes. So, inferior providers treat the patient's disease. Mediocre providers treat the patient as a person. Superior providers treat the community as a whole. That's big for public health. But understand that we're part of that public health ecosystem that's going to be doing part of that. Right? We're treating each individual person so that it doesn't go out and cause population problems. We're educating our folks so that they don't go out and cause more STIs. Right? So just keep that in mind. Anybody have any questions? Let's take a break. We shouldn't take this very long. So this one's going to be strictly on the United States Preventive Service Task Force recommendations. If you didn't know, this is a US PSTF stuff. All right. Here we're going to talk a little bit about the prevention and definitions. And by prevention, the goal of prevention is wellness, right, overall, for both individuals and the population. Okay, so public health is directed toward the population to provide information and interventions to include screening, right, which is something you guys already do, right, screening for diseases, if you notice them, and to improve the health of the community, okay, not just the individual. Okay? We just talked about that in the last section of slides that we talked about, but this one is dealing with the same thing. Prevention and public health moves interventions from the individual level, which is what we do as providers, right? We take care of individual folks, to the population level. All right. Three primary feats of prevention. Okay. The tertiary prevention is your second P. The tertiary prevention is your second P in your SOAP note. Okay? That's reduction of morbidity and mortality from an existing disease. Most of what occurs, so I take that back, my apologies. Okay, your secondary prevention is your second P. Okay, your secondary prevention is your second P. Right? That's the one that allows you to screen for stuff. Okay? That's the one that's going to lead you to an early diagnosis and prompt treatment of the disease. Not the reason why they are there to see you at the moment they're seeing you. Right? If that is part of the reason, that's part of your plan, not necessarily part of prevention. All right? So your primary one would be prevention, preventive measures that prevent the onset of the illness or the injury before the disease process begins. Secondary prevention measures that lead to early diagnosis and promote treatment of disease. Okay. And your tertiary is after it happens, that should be part of your plan, not part of your prevention, because the person's already injured. So whatever you're going to do for that injury, that part of the prevention, to make it or keep it from getting worse, is what you're going to do. All right? So the first two will be for your second P, and your last one will be for your plan itself overall. So in this one, the highlighted area is really what you need to look at. Okay? Review medical records. So this is just really talking about what you're going to do according to the DHA. Okay? That DHA-PI is your Defense Health Agency procedural instructions. It's telling you how to do PHA, Preventive Health Assessment. So if you look at B, okay, you're going to review the medical records created and care received outside of military health system. So if they've gone someplace else, you need to take a look at those records. Available data from ordered lab tests, CPS screenings or referrals. And that's the part you need to look at. CPS screening or referrals are clinical preventive services. Those clinical preventive services come from USPSTF. Okay. And then if you go to this one, CPS, right, the clinical preventive services, it tells you services recommended by the USPSTF, intended to prevent or reduce the risk of heart disease, cancer, infectious disease, and other conditions and events that impact health. Utilizing A recommendations. Have all you guys gone on to USPSTF and looked at that stuff yet? No? Okay. There's A, B, C, D, and I recommendations. When we do CPS recommendations, we try to only use recommendation A. That is the best recommendation out of all of them. Okay? We'll talk about that here in a little bit. Okay? So the USPSTF was created in 1984. Okay? And they have guidelines that are evidence-based, okay, that we put into practice. So experts from around the country are brought together by a group, AHRQ, and they review literature, they review procedures, they look at determinants of practices, they put them all together in an evidence-based manner. That is where all your recommendations A, B, C, D, and I come from when you put all the information into the USPSTF. Either app or desktop app. That AHRQ group is the Agency for Healthcare Research and Quality, and they're the ones that sit in a big giant room and start going through all the information and come up with all these things for us. Okay, and it's a volunteer panel. A volunteer panel, national experts that come together and do this stuff. The big question really becomes, what is evidence-based medicine? Okay? And that's literally making a process of clinical decisions using the best available research evidence. Okay? To work here, research evidence combined with clinical expertise and patient values and preferences. Okay? So you have three different things in there, right? You have the research evidence, which is what USPSTF is doing for us. The research evidence. The clinical expertise, that's you. That's you going to PA school, that's you keeping up with the 50 CME, that's you reading journals and articles that come out so that you can maintain your knowledge on certain things, especially if they change. That's you. And then ultimately, you're going to have to talk to that patient. Okay? All patients are not the same. Some patients don't like pills. Some patients just want a shot. Some patients don't want anything. They just want some reassurance that they're not about to die, and they'll go ahead and suffer with the signs and symptoms they've got if you tell them that they're going to be okay, because it's self-limiting. Okay? There's a combination of three different things for that evidence-based medicine. Right? Now, there is a 5-step process that most folks go through when we talk about evidence-based practice. Evidence-based medicine practice. Okay. The other 5 A's: ask, acquire, appraise, apply, and assess. These are the 5 A's. Not going to be on the test, just an FYI, because as you move forward in your education, evidence-based medicine is what you're going to hear. And you're going to hear a lot of it. Because that not only includes what you know, your knowledge from school, but it's going to include the stuff that you're going to read after you get out of here. It's a combination of both to include the discussion that you're going to have with your patients, communication-wise, to allow them to make the best decision that they can make. Right? So ask, in all reality, you're going to ask the question, hey, how can I make this better? What kind of things are out there that is going to make this thing better? It could be any topic you want. Because then what you're going to do is you're going to acquire the best evidence. You're going to go out, you're going to find a whole bunch of papers and journals that have the information that you're looking for, and you're going to read through it. You guys remember from your first semester where they started talking to you about PICO and looking through studies to make sure that they're good studies? That's what you're going to be doing during this part. You're going to be assessing whether or not it's good research or not. You're going to be willing to assimilate it and pass it on to your patient. All research isn't good research. Depends on who pays for it, and depends on what they want at the end. Right? But that's you to make up that decision when you acquire it. You're going to appraise it, right? As you acquire and appraise it, you got to figure out whether it is or isn't good. And you got to validate it. Okay? And upon who paid for it. And you're going to apply it, which means you thought it was good. I know some stuff about this. Let's put them together, and that's the information that you're going to feed your patient in order to come up with a good decision on how you want to take care of it. Right? And ultimately, you're going to assess it. Okay? Did it work? Did it make sense? Is it good? Not good? Did you have a good outcome? If you didn't, let's go ahead and try to change some stuff, or let's go find other research that may help make better decisions. So the role of evidence-based medicine, according to USPSTF, is a graded system. Okay, it's based on strength of evidence. That's those guys reading all the stuff that's out there and adding a strength of evidence letter grade to it. Right? We take whether risk versus benefit. That is another thing that you're going to do as a provider when you talk to your patients. There is a risk versus benefit with everything we do, especially if you're giving them a bunch of medications. Right? Some of those medications may interact with each other. That's a risk. Benefit is if they do work, you're going to get better. Right? So the last statement there says, does not consider cost. That's part of that socioeconomic issue. And I think during PAPI, or professional PA issues, in your senior semester, you guys might talk about some of the socioeconomic issues that we have. Not necessarily in the military, but more so in the civilian sector. But understand that this, USPSTF, the recommendation itself, does not look at cost. Some of the things may cost a lot of money to do. Some of the patients that we see may not be able to afford them. So we have to take that into consideration when we say, hey, this is what we're recommending to make sure that you stay healthy. Now the question is can they afford it or not? And there they've got recommendations applying only to those without symptoms and signs, right? That is why it's preventative. They don't have the problem yet. We want to try to keep them from getting the problem. Literally why we're doing this. Okay? You have the grading system of A, B, C, D, and I. Okay? Generally, grade A and B are what we would usually prescribe. If you saw that CPS statement there by DOD, yeah, basically said, hey, we should really stick to recommendation A. But both recommendation A and B, A highly, B moderate, show an improvement. Okay, and if you look at that last statement there, conclusion that there is no evidence of the effectiveness of the service is different from the conclusion that the service is ineffective. It's almost like a tongue twister, right? So really all that means is that there is no evidence that it works is not the same as saying it doesn't work. Okay? So we may have some stuff that's being worked on, but we don't necessarily have any evidence that it may be helpful or that it may not be helpful. More studies need to be done. Versus, hey, we did some studies and we showed that it was not helpful, so this is not good. There's a slight difference between those two. Okay, you need to know this slide because it's probably be on your test. This has all your definitions of each one of the categories. I added the last section there because it came straight from USPS's website about suggestions for practice. If you look at A and B, it says offer or provide this service. A and B. Right? So A, recommend the service. There is high certainty that the net benefit is substantial. That means when they looked at the studies and they did the work, it's going to work for your patient. B, recommends the service. There is high certainty that the net benefit is moderate, or there is moderate certainty that the net benefit is moderate to substantial. Okay? That one's a more A's can possibly work. Versus when you look at C, recommends selectively offering or providing the service to individual patients based on professional judgment and patient preference. There is at least moderate certainty that the net benefit is small. Okay? So that one already gets less than B, but this one puts the ball into your court as a provider to decide whether or not those things that fall under recommendation C are worth sharing with your patient for prevention. And then if you look at suggestion there for practice, offer or provide this service for selected patients depending on individual circumstances. Key, individual circumstances, which means your clinical judgment based on what the patient looks like. D, recommends against the service. This is a moderate or high certainty that the service has no net benefit. So that service is not going to help the patient. Okay? According to the studies in evidence-based medicine, okay, the harm outweighs the benefits. Whenever we do risk versus benefit, barring somebody's about to die, okay, you have to take that risk of mortality into account. And if you look at suggestions for practice for D, discourage the use of this service. And then I goes back to the last statement we had on the last slide, right? Concludes that current evidence is insufficient to assess the balance of benefits and harms of a service. Evidence is lacking of poor quality or conflicting, and the balance of benefits and harms cannot be determined. Okay? So that tells you they just don't know. We just don't know. Okay? And for suggestions there, okay, if the service is offered, patients should understand the certainty about the balance of benefits and harms. So if you are going to offer them, that you tell them, hey, we don't have anything that's necessarily showing that this is beneficial or not beneficial, okay, for them to decide whether or not they want to go ahead and do that. Okay. All right. Now, USPSTF is based on age, weight, height, sex, pregnancy status if it's a female, tobacco use, and if people are sexually active. That's all the information that you need to plug into this thing. And whether you're looking at it on your desktop or you're looking at it on your mobile device. Okay. So let's do this. If you don't have a mobile device because you haven't downloaded it yet, you can go ahead and go to that website and then click on the bottom left, and that'll take you to the desktop version. Okay. All right. So this patient right here, I want you to plug in all her information. Right. I'm going to plug in the information as well. She is not pregnant. She is not pregnant. Okay. So what's the very first thing that you got? Cervical screening. Women age 21 to 65. So if you look across the top, you've got all in the little tab, then you've got A and B, then you've got C, D, and I. Or if you're on the desktop, it's probably tab A, tab B, tab C. So you can just click on each one of those and it'll just pull up just those recommendations. All right. So hers is cervical screening. Great. That's one of those things that you can add in, right, for prevention. Okay, what's next? Folic acid supplementation. Is that what you guys have? All right. That's another preventive piece that you can add for your second P. Okay, it's that simple, right? Now, what does get a little bit more complicated is when you have stuff that may not match appropriately, or you have a lot of female pieces that mismatch with why they're actually seen. So if you're seeing for female issues and you have a bunch of female things in your recommendations, then you're going to have to go a little bit further than just beyond that. Like she's got vaccinations here for Hep B, right? She's got HIV screening, right? Hypertension screening. So she's got quite a few different things that you can do for her, right? Now, which one of these things do you think you'd worry about? She's a 22-year-old. Say again? Yeah, most definitely syphilis. Right? She's sexually active. Right? Right? Cervical screening would be another big one, right? Okay, on the mobile one, you won't see a total number for A's and B's, right? But if you're on your desktop, on a larger mobile device, you may see a little number next to the little tab. If you go back one, right? So go back to your main screen and just change it from not pregnant to pregnant. Okay, that should increase your A recommendations by 4. Okay, you should have gone from 8 to 12 recommendation-wise. So there's a whole bunch more recommendations in here because you're telling her that she's pregnant. Right? It's that simple. Okay? Pretty easy. Right? Okay. This one is in here because it's to remind you that anytime anyone comes to see you, vaccinations are a huge thing that you should look at, right? One of the things that you'll probably hear once you start working in every clinic, especially from the folks from the hospital, they're going to tell you every visit is a medical readiness visit, which means If you pull up their vaccination history and you see that they need something, while they're there, you can just send them right across the way there to get their vaccines. Okay, while they're there to visit you. And this way you can get medical readiness knocked out. Okay, so here's another case. Let's do this one. See what you guys get from this one. It's a much older person. What do you guys get for number one? What is it?
HIV.
All right, HIV. Yeah. What about number two? Two completely different spectrums, right? Two completely different spectrums. And do we get to, you've got syphilis, but look, the very last choice on here for recommendation A is smoking cessation. So, I mean, he's got quite a few different things that you can pick from for your prevention. All right? Now, one of the nice things about this thing is that once you put your stuff in, it'll automatically calculate your BMI, so it'll put it right up top for you. So on some of your junior clinical scenarios, you don't get the BMI given to you. So if you don't go into the BMI calculator and calculate it out, and you do go into this thing will calculate out your BMI for you as well. Okay? Alright. So here you've got the highlighted syphilis deal. Okay. There's a whole bunch of sections that'll lead you, particularly to that cardiovascular risk calculator. I'm sure Commander DeBoer talked to you guys about that stuff, right? Yes, no, maybe?
Not yet.
Not yet? Oh, okay. Well, there's a calculator. Once you get the info, you plug it in, it'll give you the risk. It's wonderful, because then you don't have to worry about it. Okay. And there you've got USPSTF recommendation grades B, 10-year cardiovascular event risk greater than 10. Okay. And then it becomes a C recommendation if that cardiovascular event risk is 7.5 to 10. And then same deal with I is just insufficient evidence. So depending upon what that cardiovascular risk calculator gives you is whether it ends up being B or C. Okay. A is your best recommendation. Okay. Here's more reminders. Make sure you check all vaccines when people come see you. Right? Because every visit is a medical readiness visit. And it's hard to get people back just for their vaccine. So if they're there to see you already, get them that vaccine. Works out for you. Anybody have any questions? Okay. I will be up here for a minute. You guys do. And I shall see you.